of the Oregon Health Authority, present the Tobacco Quit line. We're pretty excited. It's been a while since we've offered an update on the Quit line, and I'm going to hand it over to Scott.
Great. Well, thank you, Diane. Thank you, Irma. I am so happy to be here on your webinar. Let me see if I can control these slides. Yeah, I think I have control. All right. So again, my name is Scott Montaigne. I'm with the Health Systems Coordinator for the Health Promotion and Chronic Disease Prevention section at the Public Health Division. And in my section, we have the Tobacco Prevention and Education Program, which is commonly referred by its acronym TPEP. And this program has really just one clear and simple mandate, and that's to reduce tobacco-related illness and death. And we do that through a variety of state and local interventions, working with our local public health partners on promoting strategies for tobacco cessation, reducing tobacco initiation, and eliminating exposure to secondhand smoke. And one of the services that we provide to support cessation is the Oregon Tobacco Quit line. Currently, we know that about 19% of Oregon residents smoke cigarettes, and of course that is much higher when we look at specific population groups, such as low-income individuals. The good news is we know that people want to quit. The latest behavioral risk factor surveillance system data shows that approximately 80% of tobacco users mention that they want to quit. And there's a variety of motivators or reasons that they want to quit. Number one reason that we hear is health concerns. And that could be either chronic conditions that they are trying to manage, or these can be asymptomatic patients who are concerned with potential health problems later in life. Other reasons for children, social stigma attached to tobacco use, as well as the financial cost.
She wants to move over here, and I said, whose phones are these?
I'll just make a request to mute your phone if you haven't yet. We're getting a little bit of feedback.
So I'm taking this phone right now.
For this one, and then so hers, I guess she could use this one.
Hey, Scott, bear with me. I'm going to take control to mute everybody, and then I'll bring you right back.
Okay, thank you.
Well, I can't take hers because she's using it.
But so the programming is with the phone.
Okay,
All right, are you
Scott,
able to hear me?
I can hear you.
All right, great, thank you. So the Oregon Tobacco Quit line, it was launched back in 1998, so we're going on 17 years of providing this service to Oregonians. And it was back in the early 1990s when research demonstrated that telephone-based counseling for tobacco cessation was effective. And soon after that, California was the first state who provided this service. And a few years later, that was followed up by Oregon, Massachusetts, and Arizona. And today, we have all 50 states, Washington, D.C., Puerto Rico, Guam, all of Canada, and also a national quit line in Mexico. So it's really expanded over the last 25 years throughout North America. As I mentioned, the quit line is coordinated by the Tobacco Prevention and Education Program. I think I may have lost control. Okay, there it goes. And it's operated by a company known as Alere Wellbeing, and they operate quit lines for 29 states, and they also provide services to over 700 employers and health plans across the U.S., so they're very well experienced. So there are two ways to access services from the quit line. You can either call one of the numbers listed, so there's the English line, the Spanish line, and the line for hearing impairment, or you can register online. And the web-only option is standalone, so a participant can do everything, including registration on the web. And that's a good option for individuals who don't feel comfortable talking on the phone with a quit coach. Maybe they don't have good phone service because they're in areas that we would consider rural or frontier, or they don't have the minutes on their phone or can't afford to use the minutes. With that said, there is a nicotine replacement therapy dosing call that occurs. However, a participant isn't obligated to take that call, and they can avoid that by simply entering all zeros in the telephone field when they register. And that call really is just general information around safe nicotine replacement therapy use. It's available 24 hours a day, 7 days a week, which is really great service because that motivation or that urge to take that first step in quitting can come at any point. It can be late at night, it can be earlier in the day, and waiting to see a doctor or waiting for a individual or group counseling class isn't always ideal. There are just 3 criteria for receiving quitline services. 1, you must be at least 13 years old to enroll in counseling and 18 to receive NRT, and that's gum or patches that the quitline provides. You must live in Oregon, and if you don't live in Oregon, you can still call the quitline and you'll just be triaged to another state. And then finally, you must be ready to quit in the next 30 days. So there is a wealth of evidence from research over the last 25 years that demonstrates that the quitline is an effective service for supporting individuals in their quit attempts. Our go-to report for a lot of our tobacco control efforts is the Public Health Service's Clinical Practice Guidelines entitled Treating Tobacco Use and Dependence. And they concluded that after 6 months from a quit attempt, a little over 28% of patients who used counseling and medication were tobacco-free, and that's compared to about 23% who used only medication, approximately 13% who received only counseling, and then finally was about 8.5% who received no counseling or medication. So we know the chances of successfully quitting are greatest if an individual receives both medication and counseling. And it's very likely that individual is not going to be successful on their first quit attempt, their second quit attempt, but more likely it's going to be between 5 and 10 quit attempts before an individual is successful. However, that increases dramatically, as I mentioned, if they're receiving counseling and medication. So there are a couple ways people get connected with a quitline. Some callers hear about it through an advertisement or a brochure. I imagine many of you over the last few months, specifically it was between January and May have seen a quitline commercial on TV or heard it on the radio or saw one of our billboards around town. That really was helpful in getting the word out on the services that were available and drove up call volume these last few months. The other way is through referrals from a healthcare provider. So the healthcare provider will assess the tobacco use status for their patient and their readiness to quit. And if that patient is interested in quitting, they will complete a fax referral form with their provider or another staff member at the clinic, and then that form will be faxed over to the quitline. Once the quitline receives that, within the next couple days, they will make multiple attempts to reach that tobacco user and enroll them in their services. And this is a great way for providers to make a quick and easy intervention or referral to an intervention to quit to get their patients to quit smoking. And it really helps relieve the patients of the barrier of having to make that first call. Research has shown that when a patient just receives the quitline information through a brochure or a card, and we call that a passive referral, they're much less likely to make that first call and then be enrolled in the program, whereas if that call is generated by the quitline, they're much more likely to engage and to sign up and to make a quit plan with a quit coach. On this slide, you can see that you can download the fax referral form from two websites. One is the Smoke Free Oregon website, and the other one is the public health website for the state. You also can email me, and I can email you a copy of the form, or probably the easiest way is just go to Google or whatever search engine you use, type in Oregon Quit Line Referral, and the very first website that will pop up is from the Public Health Department, and you can download the form from there. So the other way that referrals can be sent to the quit line are electronic referrals, also known as e-referrals, and that's when a health system or a clinic provides an electronic file of the patient or health plan members to the quit line. It's very similar to the fax referral. It's just built in the EHR system. This, of course, is a preferred method. As being in the 21st century, the fax referral is a bit antiquated. And if you have it built into the EHR system, it just prompts the provider or the healthcare worker to assess the tobacco use, and then if that individual is interested in quitting, to make a quick e-referral, and then that will generate an outbound call from the quit line to the patient. The status today here in Oregon is we actually don't have a single clinic or health system that is sending e-referrals to the quit line. Everything is 100% fax referrals, though many other states across the country have set it up in the last few years and have had a lot of success. And we right now at the state are working with a lot of local partners, clinics, and health systems to get those established. And if the referring office or provider, if they indicate on the form that they are a HIPAA-covered entity, then the quit line will fax back information about that individual patient. So, for example, were they reached? Did they enroll in counseling services? And what's their planned quit date? And so it closes that loop, and it provides that provider with the information that they need to know whether their patient was engaged with the quit line, and what their plans are as far as their quit date in quitting tobacco. So that is a real kind of high-level overview of the Oregon Tobacco Quit Line. The only other thing I want to add is currently right now, anyone who calls the quit line is eligible, as long as they meet the criteria, is eligible for 4 counseling calls, and that is outbound calls generated by the quit line. There's unlimited amount of calls that they can make to the quit line, and then they're also eligible for 4 weeks of nicotine replacement therapy, and that's a combination of nicotine gum and nicotine patch. That's a more robust service than we have provided in the past. It depended on insurance status prior to a couple months ago when we made this change, and that range was everything from 1 counseling call to 2 weeks of nicotine replacement therapy to 4 counseling calls and 4 weeks of nicotine replacement therapy. With that said, if you are a fee-for-service on the Oregon Health Plan, so you're not a part of the TPO, you're eligible for up to 8 weeks of nicotine replacement therapy. And then some CCOs and commercial health plans have their own benefits, and so the individual may receive more counseling calls or more a longer duration of NRT. So I'll leave it right there. I don't know if we want to take questions right now or if there might be an opportunity later in the webinar. My contact information is right there. Feel free to give me a call anytime, or you can send me an email.
Okay. I will unmute the line, Scott, and see if anybody has any questions. One moment. Okay, there's a lot of feedback on the line. There's quite a bit of feedback on the line. If you have a question, perhaps go ahead and type in the dialog box, and we will call them out one by one and go through them. Okay, in the meantime, go ahead and submit your questions in the chat and or contact Scott directly. But if you send a chat, it helps everybody because everyone will hear the answer. So go ahead and chat if you've got any questions for Scott in the Oregon Quit line. We are really pleased today to have two people from Multnomah County Health Department give us their experience, lessons learned around moving from workflow to reality. I love the title of that because we know the Oregon Quit line exists. We know it's a great resource, but how do you use it? And how do you really use it in a way that gets embedded in your community health center? And how do you use it in a way that you actually get from assessment to cessation counseling to referral and then all that information right back into the clinic? So with that, I'd like to introduce Sylvia and Deborah, and they're going to take it forward.
Thanks so much, Irma. Hi, my name is Sylvia Ness. I work with the Multnomah County Health Department. And for those of you that are unfamiliar with the health department here in Multnomah County, we run 8 federally qualified health centers. So the work that we're going to be talking about is work that has been implemented in all 8 of these health centers. And I wanted to start with a little bit of background on the work. We have presented on our workflow specific to the cessation referrals to the Oregon Quit line in the past. But today, over 2 years into using the fax referral and over 2,000 referrals to the Oregon Quit line later, we wanted to really step back and reflect a little bit and share some of the lessons learned that we've had from developing and implementing our referral workflow and process. So while we won't spend time going through the workflow today, we do have quite a robust workflow that we've developed, as well as a job aid, and we'd be very pleased to share that with anyone who's interested. So a little bit of history about this work. We started off by developing this workflow with the input of all of the roles of the people who were involved in the workflow. And you'll get a chance to see a slide of the workflow in a few minutes. So you'll see that that is several different people are involved in the process. And I think as part of our lessons learned that this was really an essential piece in making sure that we had the right input as we were developing a workflow that would really work for us. Because we have a lot of other existing referrals, of course. And so we wanted to make sure that the referral that we developed would fit as seamlessly as possible into that system. The next step of the work was really vetting this workflow with leadership, including lead providers and managers, and getting their input before we moved into the rollout process. So you can see the workflow right there on the right. So what we realized is that we developed this fantastic workflow, but it really was not enough to have just a great workflow. We also had to motivate the people in our organization to care about it, or they wouldn't really want to make this referral. And that, I think, is one of the biggest lessons that we learned from this process. And part of it, I think, in looking back, is that at the time that we were implementing this workflow, there were a lot of meaningful use measurements that had come out around tobacco cessation, and that, in part, was really pushing some of the work that we were doing. And it was also really pushing the language that we used when we rolled this workflow out. And so we talked a lot about linking this work to meaningful use. And I don't know about most of you, but I'm not really that motivated by meaningful use. Maybe I shouldn't admit that, but I think, for most of us that work in healthcare, that is not what motivates us. What motivates us is really what's going to improve the health of the populations of people that we work with. That this is really the right thing to do. And so finding a way to tell the story that connects people with why they should care is a really important part of the process of rolling out something like this. And another part, I think, that we really learned is that having a training plan and a follow-up on the training plan is really important. So at the piece of the process where we were about to roll out this workflow, it was handed over to the clinics to roll out in whatever fashion would work best for them. And so some clinics rolled it out in a very standardized way, and some clinics rolled it out in other ways. So that made it really difficult for us to be able to follow up with them and to be able to ensure that we had a really standardized process. And so looking back, we're really seeing that having a training plan that includes support for the clinic managers, support for the clinic staff is vitally important. And that part of that training plan has to include what you might call elbow support, on-the-job training, coaching, some way to support staff as they're moving through the process, when they're having questions as they come up through the process. And so I'm actually going to hand this over to Deborah at this point. Deborah had provided some of this support to 2 of the teams at one of our clinics, and so she's going to be able to share a little bit more in depth what that support can look like, as well as some of the pieces that she was able to delve into from a performance improvement perspective. Deborah?
Hello. So what I was able to do, I was actually able to go and do a deep dive into the data that we had and really go back and follow through from beginning to end what was going on. And our numbers, if we go to the next slide, you can see that people were getting screened for smoking cessation. That was the part that the medical assistant did when rooming the patient. That was part of their workflow. But it didn't look as if we were actually counseling the patients. In going back and looking at the charts, though, I was looking and finding out patients were getting counseled. What was happening was that the EHR button was not getting clicked that said counseling for smoking cessation. So the work was getting done, the providers were doing what they needed to do, but it wasn't counting for the meaningful use. So it was going back and showing them this is the button that you want to push in case you wanted to count, and most of them did. So that was part of why the numbers kept increasing over time, but part of it also was that this workflow came into place and people really did have a buy-in into it and started making more of the referrals. The next slide, you can see the other thing that I found out was people were making referrals, and some providers, you can see, were making a lot of referrals, others were not making that very many. And it's on paper, the ones that were making a lot of the referrals look fantastic. But then when you look at the next slide, you can see the outcomes, whether they made a lot of referrals or not, were not necessarily better. And again, going back and looking from beginning to end, what the difference was in what was going on was the fact that the providers were actually having a conversation with their patients. And that was seemed to be the deciding factor as to whether or not they were ready to accept the services. So actually referring patients who were ready to quit, not necessarily making the screen, finding out, yes, they're smoking, okay, I'm going to give you the referral. But actually having a conversation with the patient, sitting down and saying, would you like the referral now? And then doing it.
So we decided to use the stages of readiness diagram here to think about when you would refer people in this process. We really discovered that there were some appropriate referrals, mostly appropriate, but some inappropriate referrals as well. And so thinking about what makes an appropriate or inappropriate referral, we started thinking about, well, what stage of readiness do people need to be at in order to make this referral? We don't want people who are at a pre-contemplative stage. They're just not ready yet to take any kinds of action. And it could result in a situation like what Deborah was describing. So basically, some of the people were getting referred by their provider. Perhaps they just wanted to please the provider, so they said yes. We're not really entirely certain. But in any case, a lot of them weren't ready yet. So we want to get them at a contemplative stage, at a stage where they're preparing, or a stage where they're actually ready to take action. And something else that we really discovered is that this conversation is an ongoing process. So it isn't the type of thing, as Scott was mentioning earlier, a lot of people do not quit the first time. As a matter of fact, most people do not quit the first time. So we have to realize that this is also the case in terms of people even contemplating whether or not they're ready to cut back or to quit. So we see this as something that goes as a conversation that should happen at every visit, and that will progress over time, that people will move into different stages of their contemplation as they're having this discussion with clinic staff. And we also think about it as any other disease that someone might come in with, or any other, so for instance, if someone comes in with diabetes, you're not just going to talk with them about self-management the first time they come in and leave it at that and think that their condition is managed. You're going to have an ongoing conversation with that person. And the same is the case as well for tobacco cessation. We've also found that it's really important that our clients are not just hearing this information and being counseled by one source. For some people, that trusted source may be their provider, but for other people, as I mentioned earlier, they may just say yes to please their provider when they're actually not ready. So it may actually be someone else on their healthcare team. It might be their medical assistant. It might be a team clerical assistant or a nurse. Whoever it is that makes that connection so that people can have a more honest conversation and really engage around that, it's important to share that around so you're getting the person, the client, to the right person that they can engage with. And then I wanted to share just one method that we've been using to keep this be an ongoing conversation. This was something that was developed by some of our staff, an education piece, and we're using them as screensavers in the exam rooms. One of the things we were finding is that sometimes this conversation can feel a little bit staged or unnatural, and having a way to segue the conversation a little bit more naturally can be helpful. So there are a lot of different messages that we developed. This is just an example. This one happens to be around how much money you can save and how much money people spend on cigarettes over the years. And as an example, what one of our MAs does in order to utilize this education piece in her conversation around quitting is that when someone comes into the room and she is rooming them, she turns the exam room screen to them and says, we're going to share some tobacco cessation education with you. When I come back later, we're going to have a little bit of a chance to discuss this. And then that way, the conversation that she has with them, asking them about their readiness to quit, etc., seems a little bit more natural, and it really has a different flow to it. So that's how an MA uses it. Providers can use it in that same way or in different ways. We just found that using this being a little bit more creative about how we talk about it feels a little more friendly to people.
The other thing that we also found is that one of our biggest outcomes were the patients that were unreachable. And that could be for a variety of reasons. A lot of our patients have prepaid phones that might not necessarily be active during the time that the outreach is made. But we found that it was really important when we have that referral consent signed that the phone be verified by the patient, and that we have more than one available phone as well if possible. A lot of times we were making the assumption that this was being done at the front desk when the patient was being checked in, that the phone was being verified, and we came to realize that it was not always the case. So having that second step with the either the referral coordinator or the medical assistant to verify that phone number was essential. The other part was having a way to really track and close the loop on making these referrals. When we initially started the referral process, we would fax the referral and consider it done and close that referral. Well, we weren't really tracking what the outcome was. So we started leaving those referrals open and treating it like we would any other referral, like an x-ray. You don't close it until you have that report in your hand and you know what the outcome was. And that really allowed us to actually track a lot of what the outcomes were and really get more data as to what was happening. The other thing that was interesting when we started delaying closing that referral until we got the report, is we found that the quit line was sometimes making the outreach calls 3 or 4 within 1 week. We would send the referral and we'd get the outcome report within a week. Again, with some of our patients who have those prepaid phones, that was missing an opportunity if instead you would have maybe spaced out the phone calls within a month. That gives them more of a chance to actually get that prepaid phone with more minutes in it and then get that phone call. So we worked really closely with the quit line when we found this out and got them to actually extend the time that they were able to make those outreach calls.
And I'd really encourage all of you to have those conversations with the quit line. That was something that was a good surprise for us, is how amazing they were at reacting to our requests and suggestions. They pointed out a lot of places that we could improve our process and really worked with us on the other end where we needed some improvements from their end. So it really was a wonderful partnership, and I'd encourage you to reach out if you are experiencing any barriers with your own referrals. And the other piece that they actually were able to implement for us is that because we do have a lot of clients that were unreachable, they actually agreed to review their lists every quarter. And so they would reach out again to those same clients who had dropped off to see if they could reach them a few months later. And so that for us was a really big deal, and we really appreciated that a lot. Okay, so we have really shared our biggest lessons with you, and I wanted to just summarize them because we've talked about a lot of different things. So firstly, really, really important to make sure that the development of your workflow or your toolkit is done with staff representing all of the roles that are going to be implementing it. Prioritizing training and coaching with a messaging focus of what's in it for all of us. Why do we care about this? Including the whole team in the conversation about tobacco use with the client. So not just the provider, but making sure that there are other people in the team who are partnering in this discussion. Referring clients who are ready to engage in quitline services, which really does mean that you have to figure out what stage of contemplation your client is at before you can figure out if they're ready or not for referral. Verifying that contact information is accurate and making sure that not only is it accurate, but that that's the number that client wants to be reached at. Now, clients use different numbers for different purposes, so it's important to hear from the client that they want to be called by the quit line at this particular number. Instituting a closed-loop tracking system. This is really the only way that we've figured out that we can get information back to the health team, and keeping the health team be part of this process is very important. That allows them to have continued conversations with the clients around where they are with their quit attempts. And finally, just having the conversation is a win. Realizing that this is an ongoing conversation and that what we're really trying to do is intervene at whatever stage a client is at, helping them on the road to cutting back or quitting. So thanks so much. That's all we have for you today.
Thank you, Sylvia and Deborah. That was really fantastic. Thank you so much. I really appreciated the state of contemplation and readiness to quit portion. I know we all love to look at workflows because we think that just getting the workflow together is gonna move the work, but you know, that whole piece of readiness of contemplation is such an important piece. And everyone, feel free to type in your chats. We're not going to unmute the line just because we've been having so many issues. So if you have a question for Sylvia or Deborah or Scott, please just go ahead and chat it in, and we will read it and answer it. And just another comment, Deborah, if you can speak to one more time, that you had a slide, percentage of outcomes, where you looked at the providers and whether they accepted services from the quitline or declined them. Can you tell me how you figured out that having a conversation resulted in more accepted services? Can you just repeat that one more time?
Yeah, so I actually went back and I looked at the data from the beginning to the end, from where the screening was done to the referral, and then actually went into the chart and saw what was documented. And pretty much the majority, I would say maybe 80% of the times when they accepted services, there was documentation within that progress note that a conversation had taken place.
Okay, great. That's great data to collect. That's super interesting. Do you know also how many people actually quit smoking after those conversations? I'm just curious. I don't want to put you on the spot, but.
So I had about 70 patients that I was tracking the data on, and I spoke to maybe 35 of them, and out of those, 2.
Well, doesn't always happen the first time, and 2 is great.
Yeah.
Great, thank you. Diane, do you want to, are there any questions in the chat box? Let's see, we have, bear with me. There was a question posed around the bottom of the hour, and it looks like it was directed to Scott from Kathy Mahana. I'm not sure whether this, Scott, whether you already addressed the question. If a member is in CCO, they can get additional support of the 4 calls along with the support the CCO may provide. I just got unmuted. Scott, are you able to chime in? I'm checking your mute status. You're muted. There we go.
Okay, great. Can you hear me now?
Yes, thank you.
All right. So yeah, each CCO has their own cessation benefits that they offer, and if many of them have benefits that are more robust than what we can offer through the quit line, and so that patient would receive whatever is a part of their health plan. We did a tobacco cessation survey that we fielded last year, and we published a report at the beginning of this year, which is online, and that shows all the cessation benefits as far as medication that's offered, the duration of the medication, what kind of counseling sessions are offered, and additional information around assessment and provider training. And it's for each CCO. And I can post that link to the chat box right now, and you can access that. But since that was published in, I want to say it was March of this year, we know some of the CCOs have improved the cessation benefits that they offer, and then we of course expect that they all will improve their cessation benefits as the 2016 tobacco prevalence use metric is in place.
Okay. And finally, another question, Scott, what are all the medication options provided by the Oregon Quit Line? Are these prescribed independent of PCM involvement?
So there's 2 medications that are offered, and that's gum and patch. And there's an assessment process, and if there are any red flags that pop up, the quit line will contact the patient's provider. Otherwise, they are eligible just to receive either the gum or the patch without any additional follow-up.
Thank you. Great, thank you, Scott, and thank you, Deborah and Sylvia. We have a couple more slides that we're going to run briefly through, but again, we will send these all to you. We collected a couple other workflows from some of our other clinics, just as a comparison to the workflow that Multnomah County Health Center shared. Benton Community Health Center uses a little bit of a different process when they are assessing and implementing for tobacco use and cessation, use community health navigators to do their cessation counseling, which is just a little bit of a different take. They have the MAs do the screening, and then they refer over to the health navigators to do the cessation counseling. And this is an example of their workflow and the team that they use around this area. We also have a workflow from Central City Concern, Old Town Clinic, and they are on the centricity model of EHR, and this is just what their screenshot looks like, just for comparison. They have the cessation questions in as a vital sign, the vital sign of every general office visit, and you can see that sort of towards the bottom of the page. Are you a smoker, with a couple other options, and would you like to quit? Following that, they have a really interesting workflow that I'll just share, where they use health educators to do the cessation counseling. They might be one-to-one appointments with the health educators. They might be group appointments. They might be drop-in hours. And then if a patient is interested in nicotine replacement, they refer to the pharmacy. So they bring the pharmacy team in also to do some of the work around cessation, which I thought was just really interesting as well, and something a little bit different. So those are two samples of other workflows and other team members that were brought in to the conversation. We are not going to open up the lines just because we've been experiencing a lot of feedback, but I thought this was kind of funny, and hopefully you're all chuckling. But I want to thank you all for joining us today. We will send the slides out with all of the resources to you by this afternoon. If you have any questions for any of those presenters, please feel free to forward them to them or contact OPCA, and we'll connect you with anyone who could answer your question. So thank you for joining us, and thank you for our presenters. Lastly, here's some upcoming opportunities that are happening at OPCA. Have a look. Let us know if you want to attend any of these, if you're interested, and we will, again, connect you with the right people. But thanks for your time, and thanks for your energy and commitment to tobacco cessation. Thanks. Sorry, it's top of the hour.